All right, ready to dive deep into the gut.
Always ready.
You sent over some incredible materials on GI disorders, new assessment techniques, and nursing care. Looks like we're on a mission to turn you into a gut health guru.
Well, it's amazing, how much the gut impacts the whole body.
Yeah, absolutely.
Even little issues in the GI system, they can have these big ripple effects everywhere.
That's for sure. And that makes understanding the basics super important.
Right.
Speaking of basics, something in the lecture notes really caught my eye, auscultating for vascular sounds in the abdomen, along with the bowel sounds. Is that new?
Yeah, it's becoming more common now. You're already listening to the music of the gut, so to speak, with the bowel sounds. But now we're tuning in to the rhythm of the blood flow, too.
Oh, that's a cool way to put it. So we're listening for clues about what's moving through the intestines and how the blood is flowing to those organs.
Exactly. We're using our stethoscopes to listen for brutes.
Brutes, right?
Those swishing sounds. They indicate turbulent blood flow, so we can pick up on things like aneurysms or stenosis
Okay.
in the abdominal arteries. It's like another piece of the puzzle when we're trying to figure out what's going on.
That makes a lot of sense. It's like adding another layer of detail to the picture.
Yeah, and speaking of details, let's talk about bowel sounds. Those gurgling, cascading sounds?
Oh, yeah. Sometimes they get a little lively.
Right, like borborygmi, remember that?
Oh, yeah. That word stuck with me from the notes. But I honestly never realized how much information those sounds can give you.
Well, they're surprisingly revealing. Like, if things are too quiet down there, that can be a sign of peritonitis or paralytic ileus. It's like the gut's gone silent, and that's not a good sign. But then if things are super active, you might be dealing with gastroenteritis or even a bowel obstruction.
So it's all about finding that balance. Not too loud, not too quiet.
Yeah, exactly. That Goldilocks zone.
Yeah.
And that brings us to two super common conditions that often throw off that balance GERD and PQ'd. Bread and butter of GI complaints.
Yeah, for sure. And, speaking of GRD, one thing that really surprised me in the materials was that it can actually mimic heart attack symptoms. That's kind of scary. Why does that happen?
Well, it's all about location. The esophagus and the heart are so close to each other. And so when that stomach acid splashes up into the esophagus, the pain can radiate to the chest, and it can feel very similar to angina.
Oh, wow. So how can you tell the difference?
Well, there are some key things to watch out for. With GRD, the pain might be worse after eating or lying down, and antacids might give you a bit of relief.
Okay.
But chest pain that comes on really suddenly, and it comes with shortness of breath, sweating, nausea, and it doesn't get better with antacids, that's a huge red flag.
Oh, wow.
Could be a heart attack.
Okay, so if you're having chest pain that's out of the ordinary, call 911.
Yeah, absolutely. Better safe than sorry. Now, back to GRAD. The main culprit here is often a weak lower esophageal sphincter.
The LES. That's
Yeah.
the little valve at the bottom of the esophagus, right?
Mm-hmm.
Keeps the stomach acid where it belongs.
You got it. But when that LES is weak or doesn't close tight enough, that stomach acid can sneak back up
Right.
into the esophagus, and that's what causes that burning we call heartburn.
Yeah. And the treatment for GERD seems pretty personalized. The notes talk about a step-up approach.
Right. It starts with lifestyle changes. So things like avoiding trigger foods, losing weight if you need to, and eating smaller meals more often. If that doesn't work, then you can step up to meds like antacids,
Okay.
H2 blockers, and even proton pump inhibitors. Those are the heavy hitters in acid suppression.
Oh, wow. Yeah, so it's all about finding what works best for each person.
Absolutely. Now, PUD, or peptic ulcer disease, that's a whole other ballgame. We're talking about actual sores in the lining of the stomach or duodenum.
Right, right. And the duodenum is the first part of the small intestine. Right.
You got it.
Yeah. And I remember seeing that table in the notes comparing gastric and duodenal ulcers. Gastric ulcers are usually more superficial, often in the antrum,
Right.
while duodenal ulcers are deeper and then that first part of the duodenum.
Exactly. And where they are can affect the pain patterns too. Like with gastric ulcers, the pain often comes on right after you eat,
Oh, okay.
while duodenal ulcers tend to cause pain a few hours after a meal.
Wow. That's so interesting how a small difference in location can change everything.
Yeah, it is. And we can't forget about the complications of PU. They can be pretty serious, like hemorrhage, perforation, even gastric outlet obstruction.
Yeah, the notes mention hematemesis, vomiting blood,
Right.
melena, those black tarry stools,
Right.
and then sudden really bad abdominal pain.
Those are the red flags.
Yeah, really scary stuff.
Yeah, because those are signs that the ulcer is eaten through a blood vessel or even perforated the stomach or duodenum, and then stuff is leaking into the abdominal cavity.
That's a surgical emergency.
Absolutely.
Wow. Okay, so sudden severe abdominal pain, especially with those other symptoms, that's a 911 call.
Absolutely. Early detection and treatment are key to avoiding those really bad complications.
Okay. Now, shifting gears a bit to gastritis. This time the inflammation is in the lining of the stomach. What causes that?
It can be a lot of things. Sometimes it's just a short-lived thing, triggered by meds like NSAIDs or a rough night of drinking, even one too many spicy tacos.
Oh, no.
So that's the acute kind.
Right, the acute gastritis. What about the chronic forms of gastritis?
Chronic gastritis, that's a longer-term issue. It can be caused by H. pylori bacteria,
Right.
autoimmune disorders, long-term use of certain medications, and even chronic stress.
And the notes mention that chronic gastritis can sometimes lead to a vitamin B12 deficiency. Why is that?
Well, that's because when you have chronic inflammation, it can damage the cells in the stomach that produce intrinsic factor.
Right.
That protein is super important for absorbing vitamin B12.
Gotcha.
And without enough intrinsic factor, you can end up with pernicious anemia, which causes fatigue, weakness, tingling in your hands and feet, even neurological problems.
Oh, wow. So something that seems so simple, like inflammation in the stomach, can have these huge consequences.
Exactly. It shows how important it is to get to the root of gastritis, whether it's cutting out certain medications, treating H. pylori, managing stress, or changing your diet.
It all makes a difference. Now, speaking of different parts of the GI tract being affected, gastroenteritis, or the stomach flu, seems to hit a wider area.
Yeah, you're right. Gastroenteritis is an infection of the stomach and intestines, usually caused by a virus or bacteria.
Okay.
It's very contagious and often spreads through food or water that's been contaminated.
The classic symptoms are diarrhea, nausea, vomiting, those abdominal cramps. It's no fun.
No, definitely not a fun combo. The good news is that most cases clear up on their own within a few days with rest and fluids.
Yeah, but the notes do mention dehydration as a concern, especially with young kids and older adults.
Yeah, staying hydrated is super important, especially when you're losing fluids from diarrhea and vomiting.
Right.
Sometimes, in severe cases, you might even need IV fluids to prevent complications.
Gotcha. Now let's talk about appendicitis. That one seems like a ticking time bomb,
Yeah, it can be.
especially if it's not caught early.
Appendicitis is when the appendix gets inflamed, that little finger-shaped pouch hanging off the colon.
Yeah, I remember learning in school that the appendix doesn't really have a purpose. Is that true?
Well, it's still a bit of a mystery, but there's some evidence it might be involved in the immune system and gut bacteria.
Oh, that's interesting. So what causes it to get inflamed?
Often it's a blockage,
Okay.
either from a hard piece of stool, we call that a fecalith,
Right.
or swollen lymphoid tissue. And once it's blocked, bacteria can build up and it can cause the appendix to swell and get infected.
And the classic migration of the pain starting around the belly button and then going to the lower right abdomen, that's the big sign, right?
Yeah, that's the hallmark. And the pain usually comes with other things like nausea, vomiting, loss of appetite, a low-grade fever. If you have those symptoms, especially that pain moving like that, don't wait. Get medical attention ASAP.
Yeah, because a ruptured appendix is bad news.
It is. It can lead to peritonitis.
Peritonitis, right.
That's when the peritoneum gets inflamed, the lining of the abdominal cavity, and that's life-threatening.
Wow. So appendicitis can be a gateway to peritonitis.
It's a good way to think about it. A ruptured appendix is one of the most common causes, but peritonitis can also be triggered by a perforated ulcer, diverticulitis, even trauma to the abdomen.
The notes describe peritonitis as this really intense abdominal pain, tenderness, rigidity.
Yeah.
Like a board-like rigidity and fever.
Right, and it can escalate quickly. You might also have nausea, vomiting, a fast heartbeat, and even signs of shock as your body's trying to fight off that infection.
Wow. So any sign of peritonitis is a 911 call.
Absolutely. It's a serious medical emergency that needs treatment right away.
Right.
Antibiotics, IV fluids, and often surgery.
Okay. We've talked about acute inflammation, but now let's get into the chronic inflammation. With Crohn's disease and ulcerative colitis, those inflammatory bowel diseases or IBDs, that can be so hard to manage.
They are. These are complex conditions with periods of remission and flares,
Right.
and they can affect more than just your digestion.
Right. So let's start with the basics. How are they different?
Well, location is key. Ulcerative colitis, or UC, is only in the colon and rectum,
Okay.
and the inflammation is continuous in that area. But Crohn's can pop up anywhere in the digestive tract, from your mouth to your anus.
Oh, wow.
And the inflammation is patchy, meaning there are areas of healthy tissue mixed in with the inflamed sections.
So it's like UC is a continuous wildfire, and Crohn's is more like scattered campfires.
That's a great way to put it. And remember those extra intestinal manifestations?
Hmm.
Those are more common with Crohn's.
Okay.
So we're talking about joint pain, skin problems, eye inflammation, even liver issues. It's like the inflammation spills over from the gut
Wow.
and affects other parts of the body.
And symptom-wise, I imagine there's some overlap, right?
Definitely. Abdominal pain, diarrhea,
Right.
sometimes bloody. Weight loss, fatigue, those are common to both. But the specifics and how bad they are can vary depending on the location and the extent of that inflammation.
So how do doctors figure out which one it is?
It takes some detective work. Blood tests, stool samples, imaging, those can give us clues.
Okay.
But often we need to do a colonoscopy or an endoscopy to actually see the lining of the digestive tract and take biopsies to look at the tissue.
So it's a pretty involved process to get a diagnosis. What about treatment? I imagine it can be a long journey.
It can. The goals are to reduce the inflammation, manage symptoms, and prevent complications. Medications are a mainstay,
Right.
but the specifics depend on the type of IBD, how bad it is, and how the individual responds.
The notes mention aminosalicylates, corticosteroids, immunosuppressants, and even these newer biologic therapies. That's a lot of options.
It is, and the approach is often tailored to the individual. We start with the least aggressive and escalate as needed. Sometimes surgery is necessary, especially if there's significant damage to the intestines or the medications aren't controlling things.
So it sounds like managing IBDs is a real team effort.
Absolutely. Doctors, nurses, dietitians, and of course the patient, they all have a role in finding the best approach.
Okay. Now, for our final stop on this tour of the GI system, let's go back to intestinal obstructions. We talked about those blockages.
Right.
In the intestine, either mechanical or non-mechanical,
Right.
that can be serious problems if not addressed quickly.
Right. Those blockages can create this buildup of pressure and fluids,
Yeah.
leading to pain, nausea, vomiting, and in some cases, it can even cut off the blood supply to that part of the intestine. That's when things get really dangerous.
Yeah, the notes mention adhesions after surgery, tumors and hernias as causes of mechanical obstructions, and then things like paralytic ileus for the non-mechanical ones.
Right. So those non-mechanical obstructions happen when the normal muscle contractions that move food through the intestines, we call that peristalsis, they get disrupted. It's like a traffic jam in your gut. Oh, okay, I get it. And the location matters too, right? Small bowel obstructions come on fast with vomiting and that colicky pain, while large bowel obstructions are more gradual with less vomiting but more cramping and distension.
Exactly. To diagnose an obstruction, we often use a combo of listening to the bowel sounds, assessing tenderness and distension, and then doing imaging studies like X-rays or CT scans
Okay.
to pinpoint the location and what's causing the blockage.
And then it's all hands on deck to treat it.
Yep. First, you stabilize the patient, address fluids and electrolytes, manage the pain.
Okay.
Then we might insert a nasogastric tube to decompress the stomach and intestines. And a lot of times, surgery is needed to get rid of the obstruction and repair any damage. It's definitely a team effort and sometimes a real race against time.
Yeah, it's a race against the clock when you're dealing with a serious intestinal obstruction. Early intervention is key to preventing those life-threatening complications.
Wow, this has been a real eye-opener. I'm really starting to grasp how complex the GI system is and how these seemingly minor issues can spiral into major problems.
It's all about that delicate balance, that's for sure. And speaking of delicate balances, remember those new assessment techniques we talked about earlier? Listening for vascular sounds in the abdomen along with bowel sounds? Maybe we should dig into those a little deeper.
Yeah, I'd love to learn more about how those techniques can help create a clearer picture of what's going on in the gut.
Well, imagine this. We're already listening to the symphony of your gut with those bowel sounds, but now we're adding another instrument to the orchestra, the sounds of blood flow.
So instead of just listening for gurgles and cascades, we're also tuning into the whooshing of blood through the arteries.
Exactly. And those whooshing sounds, we call those bruits, and they can be incredibly informative. If we hear a bruit over a specific artery, it could mean there's turbulent blood flow, which might suggest a narrowing of the artery, a blockage, or even an aneurysm.
Wow, so those subtle sounds can really point to some serious underlying issues.
Yeah, they can. And it's all about putting those puzzle pieces together, the location of the bruit, the patient's symptoms, their medical history. It all helps us paint a more complete picture.
It's fascinating how much information can be gleaned from simply listening.
It really is. And speaking of listening, let's go back to GERD for a moment. We talked about how it can mimic heart attack symptoms, which is super important to distinguish. But why is that? Why does the pain from acid reflux sometimes feel like it's coming from the heart?
Yeah, that part's still a little fuzzy for me. It just seems so counterintuitive that a digestive issue could masquerade as a cardiac one.
It all boils down to anatomy and those shared nerve pathways. The esophagus and the heart are so close together, and they actually share some of the same nerve pathways that send pain signals to the brain.
So when those nerves in the esophagus get irritated by acid, the brain might misinterpret the signals and think they're coming from the heart.
You got it. It's like a crossed wire. And to make things even more confusing, the pain from GERD can sometimes radiate to the jaw, neck, and arms, which are also common areas for cardiac pain.
That makes a lot of sense, but it also sounds like a diagnostic nightmare. How could you be sure it's GERD and not a heart problem?
That's where a detailed medical history, a thorough physical exam, and sometimes additional tests come in. We ask about your symptoms, when they happen, what triggers them, your overall health history. We listen to your heart, check your blood pressure, and look for any other signs that might point to a cardiac issue.
And if there's still any doubt, you might order more tests, right?
Exactly. An EKG can rule out any immediate heart problems, and an upper endoscopy can give us a look at the esophagus and stomach lining, to check for inflammation or damage from acid reflux.
So it's a multi-pronged approach to get to the bottom of it.
It is. And speaking of getting to the bottom of things, let's revisit those ulcers. Those sores that can develop in the stomach or duodenum lining. We talked about the types of ulcers and their potential complications, but let's dig a little deeper into what actually causes them.
Yeah, I'm curious to learn more about the culprits behind those painful sores.
Well, the two main villains in this story are H. pylori bacteria and NSAID medications.
H. pylori. That's a mouthful.
Haha, it is. But it's a fascinating little bugger. It's a type of bacteria that can actually survive in that harsh, acidic environment of the stomach. And for some people, it can cause chronic inflammation and damage to the stomach lining, which leads to ulcers.
So it's like this tiny, persistent invader that sets up camp in the stomach and just wreaks havoc.
That's a great way to put it. And what's even more fascinating is that not everyone who gets infected with H. pylori develops ulcers. It seems like certain strains are more aggressive than others, and some people are just more susceptible to its effects.
It's amazing how much we're still learning about the complex relationships between our bodies and the microbes that live within us.
It really is. And speaking of complex relationships, NSAIDs, those over-the-counter pain relievers like ibuprofen and naproxen, can also be major players in the ulcer game.
Yeah, I've heard that NSAIDs can be tough on the stomach, but I never really understood why.
It all comes down to how they work. NSAIDs block the production of certain chemicals called prostaglandins, which play a role in inflammation and pain.
Okay, so blocking prostaglandins helps reduce pains and inflammation, but what does that have to do with the stomach?
Well, prostaglandins also protect the stomach. They help maintain that stomach lining, stimulate mucus production, and regulate blood flow.
So by blocking prostaglandins, NSAIDs are essentially disarming the stomach's natural defenses.
Exactly. And that leaves the stomach lining more vulnerable to damage from stomach acid, which increases the risk of ulcers.
That makes a lot of sense. So if you need to take NSAIDs for pain, what can you do to protect your stomach?
There are a few things you can try. First, talk to your doctor about the lowest effective dose and the shortest duration of treatment you need to manage your pain. You could also try taking NSAIDs with food, which helps buffer the stomach acid a bit.
And I imagine avoiding alcohol and smoking is probably a good idea too.
Absolutely. Those habits can further irritate the stomach lining and make ulcers more likely.
So it's all about minimizing those risk factors and being mindful of your stomach's delicate balance.
Exactly. And speaking of delicate balances, let's move on to those inflammatory conditions that can disrupt the harmony of the gut.
Yeah, we covered gastritis and gastroenteritis, but I'd love to dive deeper into appendicitis and peritonitis. Those seem particularly serious.
They are. Appendicitis, as we discussed, is inflammation of the appendix, that little finger-shaped pouch extending from the colon. While its function is still debated, one thing's for sure. When it gets inflamed, it can cause a lot of pain.
And that classic pain migration from around the belly button to the lower right abdomen, that's the telltale sign, right?
It is. It's like a GPS for the inflamed appendix. The pain usually gets worse over time and often comes with nausea, vomiting, loss of appetite, and a low-grade fever.
And if you see those symptoms, it's a race against time to get that appendix out before it bursts, right?
Exactly, because a ruptured appendix can spill infectious material into the abdomen, and that leads to peritonitis, a life-threatening inflammation of the peritoneum, the lining covering the abdominal organs.
It sounds incredibly painful and dangerous.
It is. The peritoneum is very sensitive, so even a little irritation can trigger excruciating pain. And because it covers such a large area, the inflammation can spread rapidly, leading to sepsis, shock, even organ failure if it's not treated quickly.
Wow, so something seemingly minor like an inflamed appendix can quickly escalate into a life or death situation.
It can, and that's why it's so important to be aware of the signs of appendicitis and peritonitis and to seek medical attention right away if you suspect either one.
Okay, so what are the red flags for peritonitis? We know the pain is intense, but are there any other telltale signs?
Along with that severe abdominal pain, you might see tenderness, rigidity, where the abdominal muscles feel board-like, and fever. Nausea, vomiting, rapid heartbeat, even confusion or disorientation can occur.
So if you see those symptoms, especially after recent abdominal surgery, trauma, or an episode of appendicitis, it's a 911 call, right?
Absolutely. Peritonitis is a surgical emergency requiring immediate treatment with antibiotics, IV fluids, and often surgery to remove the source of the infection and drain any infected fluid from the abdominal cavity.
Okay, let's switch gears a bit and talk about those chronic inflammatory conditions that could affect the gut. Crohn's disease and ulcerative colitis. We talked about the key differences, location, pattern of inflammation, and those extra-intestinal manifestations, but I'm curious to learn more about how you diagnose them. How can doctors tell them apart, especially when their symptoms overlap so much?
It's like detective work, piecing together clues from different sources. First, we take a detailed medical history, asking about your symptoms, when they started, how severe they are, what triggers them, your family history. Then we do a physical exam, checking for tenderness, distension, and any other abnormalities.
So it starts with a good old-fashioned conversation and a hands-on assessment.
Exactly, but it doesn't stop there. We also order blood tests to check for signs of inflammation, anemia, or nutritional deficiencies. We also analyze stool samples to rule out infections or check for blood or inflammatory markers.
And then based on those initial findings, you might recommend more specific tests, right?
Exactly. Imaging studies, like X-rays, CT scans, or MRIs, can give us a more detailed look at the digestive tract, allowing us to see the extent and location of the inflammation and rule out other possible causes for your symptoms.
And I imagine endoscopy plays a crucial role in diagnosing these conditions, right?
It does. Endoscopy lets us see the lining of the digestive tract directly using a thin, flexible tube with a camera. We might use an upper endoscopy to examine the esophagus, stomach, and duodenum, or a colonoscopy to examine the entire colon. During these procedures, we can take biopsies, small tissue samples, to examine under a microscope.
So those biopsies provide a close-up look at the cellular level,
Okay.
helping to confirm the diagnosis.
Exactly. Looking at the microscopic features of the tissue helps us distinguish between Crohn's disease and ulcerative colitis and rule out other conditions that might mimic IBD.
It's incredible how much information can be gleaned from such a tiny sample.
It really is, and it highlights the importance of using a multifaceted approach to diagnose these complex conditions. No single test can tell us everything. We need to put together all the pieces to get a clear and accurate picture.
Okay, so let's say we've gone through all those steps and received a diagnosis of Crohn's or ulcerative colitis. What happens next? What's a treatment journey like for someone managing these chronic inflammatory conditions?
Well, it's a lifelong journey that involves a team of specialists focusing on managing those symptoms, keeping the inflammation under control, preventing complications, and improving your overall quality of life.
So there's no one-size-fits-all approach.
Definitely not. Each person's experience with IBD is unique, and their treatment plan has to be tailored to their specific needs and circumstances.
And the goal of treatment is multifaceted, right? It's not just about getting rid of symptoms.
Right. The goals are to bring the inflammation under control, relieve symptoms, prevent complications, and ultimately aim for long-term remission so you can live your life to the fullest.
Okay, so let's break down those treatment strategies. We've got medications, surgery, and supportive care. Let's start with medications. The notes mention several drugs used to manage IBDs, aminosalicylates, corticosteroids, immunosuppressants, and biologics. Can you walk us through those?
Well, think of it as a ladder, with each rung representing a different level of intervention. We usually start with the least aggressive medications and move up as needed based on how the individual responds.
So on that bottom rung, we have the aminosalicylates. How do those work?
Aminosalicylates are often our first line of defense, especially for those with mild to moderate ulcerative colitis. They work by reducing inflammation in the lining of the digestive tract, which helps control symptoms and encourages healing.
And if those aren't enough to get the inflammation under control, you might go up a rung to corticosteroids, right?
That's right. Corticosteroids are powerful anti-inflammatory meds that can quickly reduce inflammation and offer relief during flares. However, we usually prescribe them for short periods because long-term use can have side effects.
What are some of the side effects of long-term corticosteroid use?
Well, they can lead to weight gain, mood swings, sleep problems, thinning of the bones, increased risk of infections, and other issues. So we try to limit their use and taper them off as soon as possible.
That makes sense. So moving up the ladder, we have immunosuppressants. When are those typically used?
Immunosuppressants are often prescribed for moderate to severe cases of IBD that haven't responded well to other medications, or for individuals who need to reduce their reliance on corticosteroids.
So they basically dampen the immune response that's driving the inflammation in IBD.
Exactly. But because they suppress the immune system, they can make people more susceptible to infections, so we need to monitor patients closely while they're taking these medications.
And finally, at the top of the ladder, we have the biologics. These seem to be the most targeted therapies.
They are. Biologics are genetically engineered medications that target very specific proteins involved in the inflammatory process. They're like smart bombs that zero in on the key players driving inflammation in IBD, disrupting those pathways and helping to control the disease.
It's amazing how far medical science has come in developing these precise and effective treatments.
It is, and the research is ongoing. There are always new medications in development offering hope for even better outcomes for people with IBD.
And what about surgery? When does that become part of the treatment plan for IBD?
Surgery is often seen as a last resort for IBD, but it can be a life-changing option for people with severe disease that hasn't responded to medication, or for those who develop complications like strictures, fistulas, or abscesses.
The notes mention a few types of surgery for IBD: resections, strictoplasties, and ostomy creation. Can you explain those briefly?
Sure. Resections involve removing the diseased part of the intestine. For example, in Crohn's disease, we might remove a section of the small intestine or colon that's severely inflamed or narrowed. And in ulcerative colitis, we might perform a total proctocolectomy, which removes the entire colon and rectum.
And what are strictureplasties?
Strictureplasties are procedures we use to widen narrowed sections of the intestine without removing any part of the bowel. We make incisions in the narrowed area and then sew the tissue back together in a way that widens the passageway.
So they're like intestinal plumbers, clearing those blockages.
That's a great way to think about it. And then we have ostomy creation, which is sometimes necessary, especially after a total proctocolectomy for ulcerative colitis. An ostomy involves creating an opening in the abdomen for waste to exit the body. We bring the end of the intestine to the surface of the skin and attach it to a pouch that collects the waste.
It sounds like a big adjustment to have an ostomy.
It is, but for many people with severe IBD, an ostomy can dramatically improve their quality of life. It can free them from debilitating symptoms and allow them to be more active and live fuller lives.
And what about supportive care? What role does that play in managing IBDs?
Supportive care includes a wide range of strategies aimed at improving overall well-being and quality of life for those with IBD.
So it's about treating the whole person, not just the disease.
You got it. It includes things like nutritional counseling, pain management, stress reduction techniques, psychological support, and education about IBD and its management.
The notes specifically mention registered dietitians and their role in managing IBD. Why is that so important?
IBD can affect the body's ability to absorb nutrients, and some foods can actually trigger symptoms or worsen inflammation. Registered dietitians can help people with IBD navigate these complexities, personalize their diets, and ensure they're getting the nutrients they need to stay healthy.
So it's truly a team effort. Doctors, nurses, dietitians, and mental health professionals all working together to provide comprehensive care.
It is, and at the center of that team is the patient themselves. The more informed and empowered they are, the better they can advocate for their own health and make decisions that align with their values and goals.
Okay, ready for one last shift in gears. Let's go back to those intestinal obstructions. We talked about the possible causes, the symptoms, and the diagnostic process. But I want to know more about what happens after diagnosis. What are the treatment options, and how do you decide the best approach?
Well, treatment for an intestinal obstruction depends on a few things: the cause of the obstruction, where it is, how bad the symptoms are, the patient's overall health, and their medical history.
So just like with IBD, it's personalized.
Exactly. For some people, conservative management might be enough to resolve the obstruction. That could involve bowel rest, meaning the patient can't eat or drink anything to give the intestines a chance to rest and heal.
And I imagine IV fluids would be critical to prevent dehydration.
Absolutely. 5E fluids are essential for maintaining hydration and electrolyte balance when the digestive system isn't working as it should.
And are there medications used for intestinal obstructions?
Yes, we might use medications to relieve pain, nausea, and vomiting. In some cases, we might even use meds to stimulate bowel motility and try to get things moving again.
But sometimes conservative management isn't enough.
Right. If the obstruction is severe, if conservative management isn't working, or if there are signs of complications, surgery is often necessary.
What are some of the signs that might indicate the need for surgery?
Well, signs of bowel perforation, like severe abdominal pain, fever, and a rigid abdomen, those are surgical emergencies. Other warning signs might include persistent vomiting, a lack of improvement with conservative treatment, or worsening symptoms.
And what does surgery for an intestinal obstruction usually involve?
The main goal is to remove the blockage and repair any damaged sections of the intestine. This might involve simply removing the blockage itself, like a tumor or a foreign object, or it might involve resecting a portion of the damaged or blocked intestine and then reconnecting the healthy ends.
And sometimes an ostomy might be necessary, right?
Yes, an ostomy might be needed, sometimes temporarily, sometimes permanently. It allows the intestines to heal or bypasses a section that's been removed or damaged.
Wow, this deep dive has been incredibly informative. I'm seeing the digestive system in a whole new light. It's not just a simple tube processing food, but this intricate and vital organ system that's crucial for our overall health and well-being.
You're right. The digestive system is far more complex and impactful than most people realize. It's a delicate ecosystem that needs balance and harmony to function properly. And as we've seen, when that balance is disrupted, it can have significant consequences for our physical and emotional well-being.
It really is amazing how interconnected everything is in the body.
It is.
And it sounds like recognizing those connections is really key to understanding and managing these complex GI conditions.
Absolutely. And that brings us back to Crohn's and ulcerative colitis, those inflammatory bowel diseases.
Okay.
Remember, these aren't just digestive disorders.
Right.
They can have effects throughout the entire body, impacting overall well-being.
Yeah, for sure. We talked about the diagnostic process, the blood tests, stool samples, imaging, endoscopy, but I'm curious to learn more about the actual treatment strategies for these conditions. The notes mention medications, surgery, and supportive care, but it seems like the approach is very individualized.
You're exactly right. There's no one-size-fits-all approach when it comes to IBDs.
Okay.
The treatment plan really depends on a lot of factors. The type of IBD, how severe the symptoms are, where and how extensive the inflammation is, whether there are any complications, and the individual's overall health and preferences.
So it's really a collaboration between the patient and their healthcare team to figure out the best way forward.
Exactly. And the goal of treatment is multifaceted. It's about controlling the inflammation, relieving symptoms, preventing complications, improving quality of life, and ultimately trying to achieve long-term remission.
Okay, so let's break down those treatment strategies a bit. We've got medications, surgery, and supportive care. Let's start with medications. The notes mention a whole arsenal of drugs used to manage IBD: aminosalicylates, corticosteroids, immunosuppressants, and biologics. Can you walk us through those?
Sure. Think of it like a ladder, with each rung representing a different level of intervention. We usually start with the least aggressive medications and then escalate as needed based on how the individual responds.
So at the bottom ring of that ladder, we have aminosalicylates. How do those work?
Aminosalicylates are often the first line of defense, especially for mild to moderate cases of ulcerative colitis. They work by reducing inflammation in the lining of the digestive tract. That helps control symptoms and promote healing.
And if those aren't enough to bring the inflammation down, then you might move up to corticosteroids, right?
Exactly. Corticosteroids are really powerful anti-inflammatory medications that can quickly tamp down inflammation and provide relief during flares. But we usually prescribe them for short periods because long-term use can lead to some unwanted side effects.
What are some of the side effects you see with long-term use of corticosteroids?
Well, long-term use can cause things like weight gain, mood swings, trouble sleeping, thinning of the bones, increased risk of infections, and a host of other issues. So we try to use them sparingly and wean people off of them as quickly as possible.
Makes sense. So climbing up that ladder a bit further, we come to immunosuppressants. When are those typically used?
Immunosuppressants are often used for moderate to severe cases of IBD that haven't responded well to other medications or for people who need to reduce their reliance on corticosteroids.
So they basically dial down that immune response that's driving all the inflammation in IBD.
Exactly. But because they suppress the immune system, they can increase the risk of infection. So it's super important to monitor patients very carefully while they're on those medications.
And then finally, at the top of the ladder, we have the biologics. These seem to be the most targeted therapies, wouldn't you say?
They are. Biologics are genetically engineered medications that target very specific proteins involved in that inflammatory process. They're kind of like smart bombs, zeroing in on the key players that are driving inflammation in IBD, disrupting those pathways, and helping to get the disease under control.
Wow, it's incredible how far medical science has come in developing such precise and effective treatments.
It really is, and the research is constantly moving forward. There are always new medications being developed, offering even more hope for people with IBD.
That's encouraging to hear. What about surgery? When does that become part of the treatment plan for IBD?
Surgery is often considered a last resort for IBD, but it can truly be a life-changing option for people with severe disease that hasn't responded to medications, or for those who have developed complications like strictures, fistulas, or abscesses.
The notes mention a few different types of surgery for IBD, including resections, strictureplasties, and ostomy creation. Can you give us a quick overview of each of those?
Of course, resections involve removing the diseased portion of the intestine. So, for example, with Crohn's disease, we might remove a section of the small intestine or colon that's severely inflamed or narrowed. And in ulcerative colitis, we might perform a total proctocolectomy, which removes the entire colon and rectum.
Okay, and what are strictureplasties?
Strictureplasties are procedures used to widen narrowed sections of the intestine, but without actually removing any part of the bowel. We make incisions in the narrowed area and then sew the tissue back together in a way that widens the passage.
So they're like intestinal plumbers clearing out those blockages.
That's a great analogy. And finally, ostomy creation. This is sometimes necessary, especially after a total proctocolectomy for ulcerative colitis. An ostomy involves creating an opening in the abdomen for waste to leave the body. The end of the intestine is brought to the surface of the skin and attached to a pouch that collects the waste.
It sounds like it would be a big adjustment to have an ostomy.
It is. But for many people with severe IBD, an ostomy can greatly improve their quality of life. It can free them from debilitating symptoms and allow them to be more active and live more fulfilling lives.
That's good to hear. Now, what about supportive care? What role does that play in managing IBDs?
Supportive care covers a wide range of strategies aimed at improving the overall well-being and quality of life for people with IBD. It's not just about treating the disease itself, but supporting the whole person.
So treating the whole person, not just the disease.
Exactly. It includes things like nutritional counseling, pain management, stress reduction techniques, psychological support, and education about IBD and how to manage it.
The notes specifically mention the role of registered dietitians in managing IBDs. Why is that so important?
IBD can affect the body's ability to absorb nutrients, and some foods can trigger symptoms or make the inflammation worse. Registered dietitians can help people with IBD make sense of all that and personalize their diets to make sure they're getting the nutrients they need to stay healthy and well-nourished.
So it's a real team effort. Doctors, nurses, dietitians, mental health professionals, all working together to provide really comprehensive care for people with IBD.
It is, and at the center of that team is the patient themselves. The more informed and empowered they are, the better they can advocate for their own health and make choices that are right for them.
Absolutely. Well, we've covered a lot of ground in this deep dive into the GI system, from those subtle sounds we can hear with a stethoscope to the complex surgeries used to address these life-threatening conditions. It's been a truly fascinating exploration.
It has, and I think the key takeaway is that the digestive system is so much more intricate and influential than most people realize. It's a delicate ecosystem that's vital for our overall health and well-being.
And while the conditions we discussed today can be complex and challenging, medical science is always evolving, offering new treatments and hope for a better quality of life for people living with GI disorders.
Absolutely. And remember, knowledge is power. The more you understand about your own body, the better equipped you'll be to advocate for your health and make informed decisions about your care.
So to our listeners, we leave you with this thought. The gut is often called our second brain, this complex network of nerves and bacteria that plays a vital role in our physical and emotional well-being. What can you do to nurture your gut health and help this vital system thrive? Keep learning, keep exploring, and keep listening to your body. Until next time.